I'm going to go over a little bit of my background, but as I was approached about talking about taking care of our patients, particularly, patients with a substance use disorder. Our patients with a substance use disorder, if we're honest, they can be challenging to take care of. And so, but also extremely rewarding to take care of. So that's what I want to focus on, is that, yes, there are challenges. Most of these challenges can be met with a little bit of education. Actually, not that much. A lot of these things are relatively straightforward to learn, and then a lot of empathy. It's not easy to be one of our patients, meaning a patient with a substance use disorder. It's not easy. I talk to patients about this all the time. There's a lot of things that are misunderstood when it comes to taking care of our patients. And so this is a common area of misunderstanding, I would say, is pain in general. And so that's why it's one of the areas that we're going to focus on. And this is not like a kind of a how-to lecture mostly. There's a little bit of that. But I think what I really want to focus on is more of an approach, a general approach and a general philosophy when you are treating a patient who has a substance use disorder and has pain. And that general approach, to me, that has served me well anyway, personally, very well. And then hopefully it served the patients well. So if we can go to the next slide. So this is the kind of, this is one of these stupid pictures, but this is how a lot of times this topic makes everybody feel. Providers, patients. This is a topic, meaning pain, that is wrought with a lot of potential problems. So next slide. We can skip the next slide. Actually, I have no disclosures. And so this is what we're going to be talking about, and I kind of already reviewed that. We can go to the next slide. I just thought, just go a little over my own background and why am I sitting here talking to you. And I've been very fortunate in my experience in my career. I never really intended to do addiction medicine. That is my primary focus of my practice now. I was trained in internal medicine. I actually did my residency at Dartmouth. And I came back to Buffalo and started working in a rural health clinic. That was what I thought I would do. And a lot of things happen in our system, but I ended up then in the inner city in one of what we call our mission sites. And that was right as this opiate epidemic was really heating up. And I inherited just a ton of patients like that. And I really basically just decided I have to teach myself how to do a better job with these patients. And I started doing a lot of reading. I did some time with a bunch of great mentors, and eventually started doing it more in my practice. Eventually the hospital asked me to formally become the medical director of our opiate treatment program, our methadone clinic. We have 3 now. So things have just kind of grown since then. I was the first provider of buprenorphine in Buffalo. I've been doing that since 2005. And really, things have really just kind of gone from there. But part of the reason I sometimes bring this up to audiences, particularly primary care audiences, is I'm a primary care physician. I had no particular training in addiction medicine when I started. It became a whole career. I have no particular resources. I mean, now I do with some of our other, treatment clinics. I have a lot of support, but the hospital never gave me a resource. I never had anything assigned to me, so to speak. As it stands today, most of our buprenorphine patients are still treated by me and a nurse, my same nurse as I've had for a long time. So I know that this can be a challenge, taking care of these patients sometimes, but I also know that it can be done. I absolutely know it. And, I know that it doesn't require necessarily a lot of extra resources or things like that in the practice to be able to do it well. So yeah, if we can go to the next slide. All right, so this is a quote from, if we could go back, thank you. So this is a quote from an article from the Pain Management Nursing was the journal. And I start out with this, and I'm not going to read it, but I like it because it sort of sets the stage that taking care of patients with pain, I mean, that's what we're supposed to do, right? As providers, that's one of our top jobs, and that applies to all patients, including patients with a substance use disorder, and that can be a challenge to take care of patients with a substance use disorder, but we have to rise to the challenge. We really need to be able to rise to the challenge and be able to assess and approach these patients in a reasonable fashion. And so that doesn't always mean that we exactly know every right, quote unquote, thing to do. But I think, again, if we have sort of that general approach that I'm going to do my best here, I'm going to, try to address this patient's pain to the best of my ability, have some I'll say sort of fundamental understandings of how to approach that, then usually, in my experience, usually things can go okay. When things don't go okay is when there's ignorance, classic ignorance of I don't understand what's happening, so I do the wrong thing, and or the attitude is like, well, you have an addiction problem, I can't really help you. And I realize that nobody kind of consciously wants to do that, but I'll just tell you in my experience that practically that happens an awful lot to our patients. It's like, you have an addiction diagnosis, well, maybe you should be going to see someone else or whatever. And the patients, suffer because of that. So next slide. This is, of course, pain in general is a big problem. There's a common, and everyone knows this, a common complaint. And the that's on the next slide, but our methadone patients, and this is probably a low percentage here, but at least a third of our patients on methadone, I'll say my patients on buprenorphine too, have a chronic pain problem. Many of the patients that we see started their path, so to speak, to addiction because of a pain problem. So it's extremely common. We can't really avoid it. And even if you don't have an addiction, it's about a third of the population has some sort of painful condition. So if we go to the next slide. So patients with addiction they very commonly have chronic pain. And I often say that addiction is cruel, and it's terribly cruel in many ways. And one of the ways it's cruel is that, particularly opiate addiction, that here we got using an opiate on the surface of which we use opiates to treat pain, and then through the course of my addiction and escalating use and all of the consequences thereof, including physiologic consequences, that really it starts to make it so that I experience pain worse. So our patients particularly with opiate addiction, have a worse experience of pain in general than patients who do not have that diagnosis. And as this slide is basically trying to point out here, is a complicated issue. Some of it is maybe some of the psychology of addiction, but clearly some of it is the physiology of addiction, what it does to the physiology and the normal sort of pain pathways, and then how patients then experience that. And it, in and of itself, pain is a very significant trigger for our patients then to use, self-medicate, which again, that's not to say that we condone that. That's just a reality. It's just a reality. Oftentimes, if the pain isn't addressed properly, it's putting their recovery at risk. So next slide. All right. So again, this is the first one is a little quote from that same journal article that I referenced earlier, and I liked it and so that's why I put it as a quote, like that, this is my experience of this, is that there's this tension that can start to develop. And it's, you know, on the surface of it, certainly it is reasonable, because on the one hand, we have a patient in front of us who has pain, and the pain can be difficult to assess, you know, right? There's absolutely no way for us to exactly know what the patient's experiencing. And on the other hand, we have this patient, the same patient, who has a chemical dependency, a substance use disorder, and we don't want to do something to them that may cause them trouble in that regard. And so there's oftentimes this difficult issues that start to arise, and it can create tension for basically everyone that's involved. Next slide. This, I looked through these slides earlier, and I forgot, I don't have the reference here from the article, but this is an article I ran across years ago, and it was talking about, it was interviewing residents actually, and kind of how they feel about patients with addiction, and then the patients and how they feel. So, but the sort of the general gist of the article is sort of like we can oftentimes don't have very good sort of opinions about the patients I'm talking about with addiction, and we have common misperceptions about them. Like we say, if they ask for a medication, they are they're obviously just trying to manipulate us or trying to get something from us or whatever. And a lot of these things, you know, are not true. They may be true, but they are not universally true. So a lot of the times we don't feel great about taking care of these patients. We have, sometimes it's really out front, but usually it's a sort of undercurrent of some bias too that's associated we may not even realize. And so to try to be mindful of that as we start to take care of these patients. The next slide. Oh yeah, I'm sorry. Here's the quote for the article, the reference. So this is what happens. This is what was common when you interview the residents. This is the common things. This is my experience of this, and I deal with the residents too and things. So that there's a lot of uncertainty, and I mentioned the tension earlier between the pain, what's addiction, what's going on, with a common misunderstanding like, oh, a patient with addiction can't get an opiate. And maybe they shouldn't get an opiate, but there's nothing that says they can't get an opiate, for instance. We have concerns about the side effects. This is a very common one in my hospital system. You have a patient come in, known opiate use disorder, very high tolerances to opiates, right? And they have a clearly painful procedure or something, and everyone's afraid to give them an opiate, think they're going to overdose them or something like that. This is a common problem, and it's just a simple misunderstanding of what's going on with the patient. And then the last bit of this is fear. And this one is the one that I think is really the most common thing and is the undercurrent for what drives a lot of the behavior. That we are afraid, potentially, of these patients. We're afraid of being deceived. We're afraid of being taken advantage of. We think they're going to divert the medications or whatever. We think that we're going to cause them to relapse. And so that is kind of like a common, I'm of course saying this is always the case, but this is a common way that the patients are sort of seeing us. This is how we are presenting ourselves to the patients. This is what the backdrop of the experience oftentimes. Next slide. And then the patients, of course, have fears too, and concerns. And this is extremely common. I've talked to patients many times about this. And so they have some of the same kind of concerns and oftentimes misunderstandings too. They think that, oh yeah, if I take an opiate, I'm for sure going to relapse and have my addiction's going to become very active again. That is, generally speaking, that is not true. When a patient has a severely painful, condition, and right, will use surgery. Again, it's not always clear, but some things are clear. Oh, this patient just had a major surgery. So if we don't treat that pain, actually the risk of relapse is probably greater than if we did. They have fears of how they are perceived by us. Our patients, my patients with a substance use disorder, oftentimes have a high distrust of medical providers. That's a reality. That is sometimes based, on their own misperceptions, but oftentimes is based on their own negative interactions with us, frankly. And then they have, commonly they have fear that if they're on medication-assisted therapy, say, that someone's going to stop it. And that happens a lot, actually. In our hospital system, that happens with distressing regularity, despite all the work we have done to try to make sure that that doesn't happen. And patients who are maintained on buprenorphine, say, or methadone, if they end up in the hospital for some other medical condition, those medications should almost never be stopped. So next slide. All right, so that's just sort of a little almost sort of introduction to all this. Again, so sort of thinking about this whole kind of topic. And so this is a complex issue, all right? I think that we need, and most of us are, this is what medicine is really, right? I mean, it's just not an exact science as much as we'd like to make it. Like, we have to be comfortable with some uncertainty here. Recognize that times it's not exactly clear what the right way forward is, but to try nonetheless then to do our best. And so that we can be able to advocate for our patients, right, and to treat them well. To recognize that certain realities, like I said, that like their medication should not be stopped. Like, okay, this patient is likely experiencing pain. They're very, very likely they're having a worse pain experience than the exact same patient with the same, same patient who had the same procedure, say, who doesn't have addiction. And that usually means that they require more intensive treatment, not less. Almost always, and I already mentioned this, most of the time, patients with addiction history have their pain treated less than patients who do not. So next slide. All right. So this is, what can I say? Well, how can we proceed? What's the proper way to proceed? And we just have to, recognize these issues, as I kind of already said, and try to address it the best we can. The next two bullet points, the second bullet point, this is, I don't want to make this oversimplified here at all, but this is the way I approach it, and I like simple. So this is one of the things that I do with myself, actually, and I do with the residents all the time. Dr. Updike, they call me a lot. Patient with methadone, I just had surgery. What am I supposed to do? Okay, well, what happened? Oh, they just had their gallbladder out. Okay, well, what would you usually do? What would you do if the patient didn't have an addiction diagnosis? Then, they tell me whatever they would tell me. And so then I said, well, do that. All right, so we have a sort of backdrop, right? Or we have experience with this. And it's just for some reason, the addiction diagnosis oftentimes just sort of gets us off kind of in the wrong direction. And so if we can just sort of take a step back, oh yeah, okay, this is what's going on here. These are the kinds of ways I would usually treat this diagnosis, and to see, can I apply that to this patient? And again, I know that sounds very simple, but I mean, it happens, and I'm like, unfortunately not exaggerating. In my clinic, it happens almost every week. And we have a lot of patients, but like a patient's like, oh yeah, I have arthritis and my doctor won't give me Tylenol, for instance. I'm like, well, why not? And it's like, well, because I'm on methadone or something. And so that's the kind of thing that is very easy to avoid, right? I mean, some of these things to me are completely non-controversial. Like almost every intervention for pain that you can imagine, other than opiates, shouldn't really be that controversial for the most part. Right? I'm obviously kind of painting with a broad brush here, but it's the opiate that can cause, you know, some controversy, which I understand we can talk about a little bit. We're going to talk about a little bit more. But in general, you know, these patients, we should be approaching them in a very similar manner like we would any other patient. It's very straightforward. The last bullet point is just the kind of thing that I hear all the time from the patients. Oh, Dr. Updike, they treat me like I'm an addict. And, you know, that's kind of a real loaded statement, really, if you think about it. Because in a way, really what they're saying is I'm just not treated well. That's basically what they're saying. And, you know, I like to have a discussion when I hear this kind of thing with the patients, because, like, trying to get, like, what they mean by that, what their experience was, but then also to be able to do a little education with the patients. Well, you do have an addiction diagnosis, though. And so a lot of this is how we approach it. And I say, well, you know, if you had diabetes, I wouldn't ignore that. Yeah, if you had surgery, I would, you know, want to treat your diabetes, but sometimes the diabetes might affect how we treat your pain too. And it's the same thing with your addiction. Your pain, you should have your pain treated properly, but we shouldn't ignore the fact that you also have a diagnosis of addiction. So, you know, that's kind of the way I approach all of this, is sort of a simplified approach, recognizing that the patient has, you know, a certain comorbidities, and trying to come up with the best treatment plan that we can to address all of that. Next slide. All right, I don't want to spend too much time on this. I'm sure, I don't know what everyone's experience is, actually, so I shouldn't say this, but most people, I think, are aware of, at least, of the CDC guidelines from 2016. They don't exactly apply to our patients very well, particularly patients who are on medication-assisted therapy. This is kind of a good, and I don't want to spend too much time on this, kind of a good thing to think about in general for our patients, though, that these guidelines, while we could say maybe well-intentioned, also have caused potentially a lot of trouble for patients as well. And one of the big things, I mean, probably the most controversial thing, is really the 90 milligram morphine equivalency, which is like the fourth bullet point there. Because a lot of the other things in the guidelines are, you know, relatively, I think, straightforward. You know, doing proper assessments, minimizing opiates, using non-opiate based therapies, and a lot of those kinds of things, monitoring patients closely. But the 90 milligram morphine equivalency, you know, that kind of thing, that doesn't apply to our patients well. You know, they are highly tolerant to opiates. And, you know, whether or not that should be universally applied to patients is actually, I think, a controversy as well. So next slide. And I know, you know, unfortunately, I don't think you can read this very well, but this is the response from the CDC to Dr. Alford. I don't know if any of you know who he is, but he's in your neck of woods. He out of university, Boston University, and he's really, to my mind, he's really the expert in all of this, pain and addiction and proper approaches to it. And he had written a letter outlining his concerns, and it was signed by many practitioners, particularly in regard to the 90 milligram ceiling. And the response from the CDC was that it was never intended for that to be applied. First of all, just as universal, like no one should ever be over 90 again. And it was not intended to be applied to patients who were already on higher doses of opiates. It was not intended to sort of kind of go back in time. That what we're supposed to do is kind of look at where patients are, assess whether or not they might be able to be weaned, to do that moving forward in a cautious manner, but not necessarily to do that in every case, and to continue to assess the risks and benefits of ongoing opiate therapy. I mean, that makes sense. And part of the reason I bring this up is because in our neck of the woods, and I would guess in many necks of the woods, that many patients basically were rapidly taken off of opiates. And that caused a lot of problems. that caused a lot of problems. So we have to have, I think, a balanced approach when thinking about opiates. In general, for sure, whether our patients have an addiction diagnosis or not. Next slide. So this is kind of the practical part of this. This is my own little thing that I call the 4 Ps. I do this with the residents a lot. So as I mentioned, my experience of this is that the pain diagnosis can throw things, kind of into a tizzy sometimes. So to take a step back, and I do this a lot, to reassess what I'm doing with the patient, either acutely or chronically. And this is just sort of my little simplified approach, like, okay, have I thought about this, gone through the steps, so to speak, to assure myself that really I'm, have a solid treatment plan, and sort of have addressed all the different ways that we might address this patient's pain. And, this is imperfect, but it actually catches a lot of the things that we would generally do. So the first P is the pharmacological regimen. So I look at that a lot. Where's the patient? What am I doing? Have I maximized all the pharmacological approaches, particularly, non-opiate based treatments? And that presupposes or requires, a little bit of knowledge, what that really means. Most of that can be looked up, though. Most of us know it to some degree or another. But, have we applied it to the patient? Have I maximized then the physical kind of interventions, therapy, etc.? Have I talked to the patient about exercise, whatever? Have I maximized the procedural interventions, surgery, blocks, that kind of thing? And then have I properly assessed the patient's psychological state? And then I'm thinking about treating comorbid depression. Have I thought about using cognitive behavioral therapy, those kinds of things that have been shown to improve patients' pain. So that's just kind of a real basic, set of outline. Acutely, we're going to be usually focusing more on the pharmacological. Chronically, it's really all of these. So next slide. All right, so then when we think about these patients, really, we should be thinking about a multimodal approach. And probably most of you know this or have heard this, and then really it's just a matter of applying it. Like, for instance, we do a lot of work with pregnant women. I've done a lot of work with our obstetrical department. We used to have a lot of problems, a lot of complaints with our pregnant women with addiction who delivered at our hospital. And like all of that's gone away. And that's because we sort of took a step back, reassessed how we were treating these patients, and maximized a number of different ways of treating it, took this seriously. And now the women's experience is much improved, and the doctor's experience is much improved because of that too, right? So it's a win-win. So if the patient is on methadone or buprenorphine, as I've already mentioned, we're going to mention this a couple of times though, we should continue that. I know there's some questions coming in, and I will answer those at the end, as Carolyn mentioned. So just to be clear, that should be continued. All right, that should not be stopped. The medication-assisted therapy, whatever it is generally speaking, and it's not universal, but generally speaking, we should think of this as not being analgesic, particularly for an acute pain episode. Okay, now, particularly methadone probably has a little bit more utility to address some of the acute pain, but it cannot be relied on in and of itself to really address the pain adequately. The medication, methadone and or buprenorphine, generally speaking, should be split while in a hospital setting to maximize some of the analgesic property. But, continued, generally speaking, at the same dose, although, sometimes we might make some exceptions there. But so usually what we do is split the dosing. So if it's methadone, we get that once a day generally. Well, in the hospital, they usually get it at least 3 times a day. Same with buprenorphine. Then it'll at least have a more analgesic property that way than if we gave it once a day. And then we maximize the adjunctive treatments, okay? And this is just, this obviously it's not an exhaustive list here, but, and some of this comes right from our pregnant women, but applied to every patient. So maximizing everything that we can do. Our OBs like to use this intravenous acetaminophen now. They say they get great results with that. They do a lot of, they put lidocaine in the wound if the patient's had a C-section, try to leave the epidural in a little bit longer, use other adjunctive medications. And then, as you'll notice on the list, is actually opiates though too. And using opiates as part of this comprehensive treatment plan for our patients with opiate use disorder diagnosis is appropriate. Patients can get analgesia from opiates. The risk of using opiates is quite low, meaning the risk of, you know, setting their addiction off or whatever, particularly in a controlled setting like a hospital. The risks are minimal. So when you take an approach though of having sort of this multimodal approach, addressing all the different ways that pain, you know, may be an issue, all the different mechanisms. What our experience was, and again, I'm talking about pregnant women here, but I think applied to every patient, is that our use of opiates actually has gone down substantially in these women. So we use opiates as needed, but a lot of the times it really isn't needed because, you know, we're really addressing the pain fairly well in other ways. But it takes a plan, you know, it takes a plan. Next slide. All right, so again, I'm not gonna spend much time on this now. I sort of already reviewed it, but it's just to have a list of things. Like there's lots of different things that we could think about to, you know, try to address the patient's pain, both acutely and chronically. And some of this is, well, do I know them? You know, that's part of it. Can I access them? You know, we have a hard time accessing cognitive behavioral therapy, for instance. I have a pretty much Medicaid population here. It's difficult, but at least I'm thinking about it. Are there ways that I can access it, so to speak, on the cheap, you know? And we've worked out a lot of different ways to sort of try to make that happen for our patients, but you know, to put it together as best as we can. Next slide. I think someone's asking to put it full screen, but I think we're having some technical difficulties, so we're not able to really do that, so I'm sorry. All right, so I mentioned the cognitive behavioral therapy. Next slide. All right, and I sort of already alluded to this, but this is really the kind of the treatment standard now of treating acute pain. Patients who are on medication-assisted therapy. And these are, you know, different options. It used to be, and maybe some of you remember, that with buprenorphine, initially when we first started using buprenorphine, the recommendation was to stop the buprenorphine, start full opiate agonists, say like morphine or whatever, hydrocodone, continue that. So we're trying to continue that through the surgery and then restart buprenorphine X amount of days after the surgery so that the patient, you know, could get opiates to treat their pain. We didn't think that patients could get analgesia giving opiates while they're on buprenorphine. But that turns out not to be the case, really. And so the patients getting buprenorphine or methadone can and should get opiates as needed. The primary thing is that they clearly have a higher tolerance, and to get analgesia requires higher doses than patients who are not tolerant. So that's one of the main sort of things to remember in all of this. All of the things we would do for other patients, continue medication-assisted therapy, and if opiates are needed, to assess that properly, but that we would need to give doses that are usually higher than we would in other cases. How high? Well, I go back to the pregnancy literature and our experience with pregnant women. That if we use opiates, you're talking about doses of oxycodone of about 60 total milligrams a day, at least, to get analgesia. And so a lot of people find that to be kind of a high, but really these are modest doses for a patient with, known tolerance to opioids. So commonly, as I say, what we'll see is even if they get opiates, they'll get hydrocodone 5 milligrams twice a day, and or something like that. And if the patient's been on, medication-assisted therapy for some time, that's not going to provide analgesia. So next slide. All right, so this basically what I already went over all of this. The current really recommendations are to continue the buprenorphine. As I mentioned, you certainly can split the dose up, as I've already mentioned, and consider add other opiates if needed. Next slide. And methadone, I don't know if you run into the patients much. It's basically the same idea. Now, my experience with methadone is methadone as a split dosing does provide more analgesia than buprenorphine. A lot of the times we can get through without using opiates if we split up the methadone, use the adjunctive treatments fully, and then we don't have to necessarily use opiates in those cases. All right, next slide. All right. So this is really more of the same. As I mentioned, it used to be that we would say stop the buprenorphine, start opiates. That really is not. And I took this is actually right from the buprenorphine training, and that's why I put this in here, because people are still seeing this. But the alternative is actually the way to go, which is what I've been talking about, which is continue the buprenorphine and then don't stop it, and then treat the patient's pain properly. The stopping the buprenorphine, I don't know if any of you have experience with that, but I have tons of it, and that just it never worked good. The new recommendations are, from my way of thinking about it, much better. But just even practically, if you think about it, okay, I'm trying to gauge when surgery is, I'm going to stop the opiates. Now I'm treating opiate withdrawal and pain with a full opiate agonist. That means I have to make sure I'm giving the patient the proper dosing. Almost no one ever did. Now the patient just had surgery. They're having opiate withdrawal. Now they're having pain. It was usually kind of a mess. All right, next slide. All right, and if the patient, now this happens a lot in our hospital system. I have no idea how frequent this might happen in yours, but a patient comes to the hospital and is in active addiction, right? And has whatever going. This happens a lot. For instance, our cases of endocarditis are exponentially increased over the last two to 3 years. Very common. So what to do? Well, start them on some sort of medication-assisted therapy. In our system, usually I start the patients on methadone. The endocarditis patients are in the hospital, for 6 weeks. Start them on some methadone. Try to titrate the dose up. Add in other opiates if needed for acute pain. Maximize the other approaches, and then when the patient's discharged, make sure they get referred for treatment on an ongoing fashion. Now, that doesn't always work, but it may be the best that we can do is try to treat the pain and treat the patient properly while they're in the hospital, and they go back out there. But what we're trying to do is avoid all that, because commonly these patients show up and then they're not doing well and they're having withdrawal, and then they just leave. Then they just leave the hospital, and then that's a disaster for them. Next slide. All right, so commonly, there can be behavioral issues with every patient. I mean, that's one of the things I try to remind the staff, students, everybody, like our methadone patient. I mean, it's like if I had 1,000, I don't know what, doctors that had to come to this clinic every day, there'd be problems. There'd be problems probably. So this isn't just uniquely a problem with patients with addiction, but to do the best we can with it. That's the last thing, and that's what I usually tell myself and tell everybody else. Like, okay, we're having some issues here. What does this mean? What is really going on here? And to have a little humility, like, okay, does the patient maybe have a point? Or maybe not. Maybe they are being completely unreasonable. But still, to try to engage that and be like, here, this is what I'm willing to do. I don't appreciate how you are presenting yourself. I have this kind of conversations with the patients a lot. It's very difficult for me to take you seriously when you are acting like this. Or, you know, the patient's acting out because they're going through withdrawal or whatever. That is a common issue. And I'm doing just a small tangent. I got asked to go to a meeting in our hospital several years ago, and I sit down, and it was actually with security, and they're talking about we had an exponential increase in number of security incidents in our hospital system. And I'm like thinking, why am I sitting here? But when when we looked at all the numbers, it turned out almost every one of those patients was a chronic pain patient or a patient with a history of addiction. And this was before we did a lot of education with the staff. And these patients would come in if they were an addiction patient. What our old policy was, and we have a kind of a strange hospital system with a lot of private doctors, but generally speaking, what was happening was they would come in, the surgeons, whoever, the first thing they would do is stop their medication-assisted therapy. That's the first thing they would do. Now you have a patient who needs surgery and is in withdrawal, and now you have a security issue. That is all avoidable. That's completely avoidable. And again, it just requires a little bit of sort of thought about what I'm doing, what's really going on here, the do's and the don'ts, and all of that security stuff that we had from years ago, that's gone away totally. All right, next slide. All right, the universal precautions I put out there, that's why I hate this virtual stuff, but I'm always interested to hear how many people have even heard of it. This is a older concept promulgated by Doug Gorley, who I'm grateful to say became one of my mentors. Really he was the expert in this. He retired, pain and addiction. He's a great man. But I love this. This is actually one of the things that changed my whole practice career when I was struggling with what to do with these patients. And again, this is from like 2005. But this concept was written into most of the opiate guidelines that you see, including the CDC ones. And I'm not going to read through all this, but this is, again, I'm a big fan, if you haven't gotten it, of approaches, of a game plan. And this gives us a game plan. And I just put this in because this, to me, applies to every patient with pain. And again, I like it because it's simple. And most of us maybe already do this, but it's just sort of to give us a blueprint. Like, okay, what is the diagnosis here? What is the proper way, to treat this patient? What are the other comorbidities? Okay, this patient has an addiction diagnosis, so I have to factor that into whatever I'm doing. Some diagnoses, opiates are, contraindicated, like fibromyalgia, say. So then we don't have to worry about it, say, in those kinds of patients. But just start to think these things through. Treatment agreements, this is before this was common. So to think about, if I'm going to use opiates, I should be having treatment agreements. I should be assessing how the patient's doing. Next slide. With the intervention. If I use opiates, that it's, an appropriate trial. It's a trial. If they're not doing well, to stop it. And this is really more for chronic patients. And then to continue to review what I'm doing and to document properly. The last thing is the 4 A's. That's like the third bullet point there. Most people haven't heard of this. And this is like the backdrop of almost every pain visit that I have. I still treat a lot of patients with pain. And it's become kind of the skeleton for actually almost all of my interventions. Addiction, it works for addiction. It works for anxiety. It works for ADHD. For like if I'm prescribing a controlled substance. So when I see these patients to say analgesia, how's your pain doing? Tell me more about it, etc. So this is like when you're doing your note. How's your anxiety doing? How's your attention? How are things with your recovery if they're on buprenorphine? Aberrancy. Are you taking the medication as prescribed? Are you using any other substances? Have you been using alcohol? I mean, I've asked this to patients on controlled substances almost every visit. How are their ADLs? How are they functioning in their life? Again, this applies to all those different categories: addiction, pain, anxiety, and then how any adverse effects, how it's side effects, constipation, sedation, etc. And that's what I run through almost like pretty much every follow-up visit for these patients. And it gives you a very good place to start and a great way of documenting kind of what you're doing and why. All right, next slide. And then, you know, there's other things too in practice that we can do acutely and chronically, of course. And, you know, to just be aware of them. I love the 4A's. That's the, as I've already mentioned, really the skeleton of what I do, pretty much every patient. But, you know, then it just requires ongoing monitoring. I see these patients with addiction, now I'm talking about you. Certainly patients with pain. We don't nearly have as many as used to be, but who are on chronic opiate therapy. It requires time and it requires patience and, you know, ongoing monitoring. We see them a lot. And I think that's the way to do it. You get to know them, get to know what's going on with them. You can anticipate problems then a lot of the times. And then, you know, then to me, then it starts to become kind of exciting and fun, actually, to manage these patients that way. And then, you know, then you have some sort of idea too, then hopefully the more and more you do this, of what to do if problems arise. Okay, the patient used marijuana here. What's the proper way to intervene? Hopefully, not that I just discharge the patient. That there's are ways to address issues short of discharge or whatever. Now, sometimes that is what is required, or I can't, you know, continue to go forward like this. But in my experience of it, when you sort of take this general approach and you're trying to address issues, and the patients, you know, that's one of the things, the patients appreciate the effort. That's my experience of it. Even if we don't always really get to where we would like to be, the patients appreciate the effort, and the number of problems that we start to see actually really starts to decline. Next slide. Okay, so I just wanted to run through a case or two, and very quickly. And this is a case, you know, right from our hospital, and I mentioned this already, and I don't want to just read it all, but basically it's a patient who's on buprenorphine. He comes in with acute cholecystitis that's going to have surgery. The buprenorphine is stopped on admission, and now the patient is having opiate withdrawal, you know, has escalating pain and is threatening to leave the hospital, and then they call me. So next slide. All right, so I already mentioned this, but, you know, the acute pain can and should be addressed, and the medication-assisted therapy should not be stopped. The opiates can be used, as I've already outlined at length. Whether or not they're used, in addition to the medication-assisted therapy, what we don't want to do is stop the medication-assisted therapies. That, you know, I mean, in my experience, pretty much only ever causes trouble, which, you know, I think if we think about it, makes sense. So next slide. All right. Hopefully you can read this, see this one. This is an addiction patient. This is really more almost going back to the CDC guidelines and just sort of thinking about all of this stuff and how, what we want to avoid, you know, hopefully, when we're taking care of patients. This was a very sad case that I had, a 70-year-old man who really was doing quite fine on chronic opiate therapy. He had had a fusion. He was very active. He played racquetball 3 times a week. He had a part-time job. He had a house. He was driving. And then his provider just cut him off of the opiates. He had been on them for years, and he had never had withdrawal. He didn't even know what that was. He was really doing poorly. His granddaughter actually offered to buy him some pills, and so he kind of went along with it. Then she couldn't find the pills, and then she said, well, you know, if you try this, you won't get the withdrawals, and it was heroin. And here's a 7-year-old guy, never had seen heroin, never had any addiction, didn't even drink, and started using heroin. And like 6 months later, he's totally addicted. His life was completely ruined. He lost his job. Of course, he wasn't exercising anything more. He was homeless. And then that's when I met him. And so, you know, my point in these kinds of cases is like that kind of thing, that is avoidable. That is avoidable. And so the opiates are obviously potentially problematic on many levels, but there is still a role out there, and obviously a lesser role than we used to think, but particularly acutely, there honestly shouldn't be that much concern for many of our patients. The risks, particularly for patients actually who are on medication-assisted therapy of opiates, are low. But just stopping patients who have chronically been on opiates has risks too. That's risks too. You know, that's just something to think about too as we continue to try to make sense of all this stuff. So that's the last thing I wanted to say. I'm not sure how to take the questions, Carolyn. I don't know if you want me to read them, you to read some, and I can start to try to answer them.
Sure. Thank you so much. Let's see. I'm just scrolling through. Because we're limited on time, I'm just going to grab a question that I see. Bear with me one second. I see names and hospital affiliations. Do you see, Dr. Updike, do you see?
Someone did ask me a question, and people with an opiate addiction have a higher threshold for how much is needed. All right, so I think there's a question about opiate tolerance and how long that is an issue. That's a hard question to answer. Basically, though, if a patient's on medication-assisted therapy and they remain on medication-assisted therapy, you know, their tolerance continues to be high. Now, so that's ongoing as long as that's the case. Whether or not tolerance resets itself, if a patient is, say, gets off of opiates and, you know, then is not on medication-assisted therapy either, that's a good question, and I don't know the answer to that. So we would think that would occur, but I don't know that's the case. I don't know. All right. There was another question. Oh, jeepers. What is the dose of intravenous acetaminophen? Oh, boy. That's an excellent question. I don't know that answer. Sorry. I don't do it. The OBs do it. So I don't know. You know, unfortunately, I looked that up. I can look that up and let Carolyn know maybe, or, you know, ask the guys. Sorry. Was there any other one?
If you have a question, throw it in the chat. I don't see too many more.
All right, so it is common to see drug court patients not treated properly for pain with opiates after surgery. They are penalized or stigmatized. The judge don't believe that a provider will treat with opiates if they request not to be treated with them. Okay, so this is a common issue. And if I just say opiate court, or like, there's lots of different potential situations where there might be problems. And I don't want to sound too simple, but this is where I say to myself, I just do the best I can. We can't control everybody. Certainly, I don't mean to laugh. I work with the courts a lot. We can't control a judge. But what we can do is to try to advocate for our patients and try to educate people. I have actually gone into pretty much every court in Buffalo and given talks to judges, and that kind of thing helps. You know, if you think about it, there's no exact reason why a judge should know what's going on. And yeah, they veer off, honestly, a lot of the times into areas they shouldn't go. But, you know, that's life. I deal with it with the patients as much as I can. Like, listen, you have multiple realities here. My job is to take care of you the best way I can, medically speaking. There may be other things to think about too, but we're just going to try to make those things work together. So I would try to educate judges if that's a bit of an issue, and then to do what's right for the patients. And as I've already mentioned a number of times, potentially using opiates is appropriate. There is this misunderstanding that, you know, it's going to harm the patient. Acutely, that's almost never the case. And basically the question mentioned, and I didn't really focus on a lot in the talk, just sort of touched on, the patients think that too. The patients do think that. And, you know, that's understandable. Opiates ruin their lives. But to try to get them to understand, it happens to me all the time. Oh yeah, I'm going in, I'm having my gallbladder, I'm not taking opiates, no way. How is that gonna work for you? How's it gonna work for you? I understand, and I appreciate your concerns. But that just because you have a history of addiction, that doesn't mean that you need to be brutalized here. This is gonna be very difficult, you know, and we have to think this through. So, you know, to have that talk with the patients too. Okay, so this is another, so there are higher complication rates in patients with on chronic opiate therapy and medication-assisted therapy. Ortho colleagues whose complications rates affects their practice. How to get everyone on board. I'm not sure if I understand that question or if it's more of a statement. So I'm sorry, I'm not sure if I can answer that question. There is some literature, you know, like the chronic opiate therapy patients do have more complications, you know, with other medical procedures and things like that. But to me, still the issue is how best to address this. A lot of what I said about the medication-assisted therapy really can be applied to patients with chronic opiate therapy as well. It's more or less the same approach. Patients who have been on, you know, opiates for the last decade and then have to have a surgery, you can't just stop those opiates, nor can you necessarily expect those chronic opiates to address their acute pain diagnosis. And really the untreated pain, to me, that's going to cause more trouble at the end, no matter what. All right, so why is it a problem interaction with medication-assisted therapy when a patient with opiate use disorder uses marijuana, for example, medicinal marijuana, which is legal? Well, that's a good question. I guess I'm not necessarily, I don't believe I said it was a problem, but I don't think that it is necessarily a problem. You know, when you think about other substance use, and actually we're going to talk about this more on Thursday, right? So that's really what Thursday's talk is about, if anyone can join us for that. But, you know, the role of marijuana, I mean, that's a huge topic, but marijuana, we've got to be honest with ourselves, you know, the marijuana itself, is that a highly problematic substance in regards to harm to the patient? Not directly. It really gets more back to a recovery issue, though, as far as I'm concerned. So, like, there are issues with it. But if the question is, well, you know, is there some direct sort of interaction, complication of marijuana, particularly medical marijuana, in a patient on a medication-assisted therapy? No, not directly. But I mean, I think we do have to admit that the role of it is still unclear. That's the way I would say it, look at it anyway. And, you know, I have certainly had patients who seem to respond quite well to it. That's all anecdotal, really. You know, the literature still on it isn't great, you know, for whatever that's worth. So we have the anecdotal, some literature support for some conditions, right? But to get to your question, I don't necessarily think that it is a problem per se, but it has to be thought of, I think, like in the context of like we would look at any other intervention, the relative risks and benefits here for this patient. What do we know about it? How should it be applied? All of those things. There's a lot of questions, I guess. So I think, you know, there's a role potentially for it, but I think that it's not exactly clear. And from my perspective, you know, it is something that we think about using and have used, particularly for some of our chronic patients. And as I say, anecdotally, we have some patients who seem to do okay with it. All right.
Are there any other questions? Oh, there's one.
Have you run across patients, who genetically don't convert? So this is about whether or not, if there are some patients who don't respond to certain opiates because they are not able to metabolize it to, you know, its active metabolites that require morphine or dilaudid. That's a high level question. I'm a simple person. I probably have run across those patients before, but I just couldn't tell you. I mean, I don't do that kind of testing. There was a little while in our pain practice where we did some of that kind of testing, but that's been many, many, many years ago now. And I haven't done it recently. You know, so I can't answer your question directly, but just indirectly. And I did allude to it, that this gets along the lines of, well, some patients respond to some therapies better than others. And a lot of the times, if we think that if a patient says, oh, well, I need morphine, that's just like a manipulation or whatever. And it may be, but it also may be, you know, this kind of thing. It's clear that, you know, there's a number of different mu subtypes too. And so this gets back to this kind of the same issue where some people respond better to some opiates than others. And that, I mean, that's just a reality. And that's very difficult though to determine, you know. And so that's why for me then it's a little trial and error. And if I was going to give a patient hydrocodone, then, you know, an equivalent dose of morphine, I really wouldn't have a big problem with that. So sometimes, you know, you have to work through that a little bit. But determining that up front, that's difficult to know sometimes, very difficult to know. And the testing is difficult to do. And, you know, at least in my experience now, it's rarely done. And that gets back to the whole, you know, people don't want to use opiates anyway. So I take a little more practical approach to it, a little trial and error.
Well, it's 8:10. If there are no more questions, I think we can wrap it up. Thank you so much, Dr. Updike. That was phenomenal. I've recorded it, so we can share with some folks. If anybody has questions that come to mind after we all leave each other, certainly, I will email all of you Dr. Updike's email.
Please do.
Wonderful. And yeah, I think that's a wrap. Hopefully we'll see most of you guys on Thursday. I'm so sorry for the technical difficulties. This is my first time. I apologize. I'm learning. It's not that easy.
We did okay, I think, you know, all things considered.
The slideshow view.
Yeah, we'll try to work that out.
We'll figure that out.
Yeah.
All right, everybody.
All right,
Thank you
thanks.
so much.
We'll see you.
Bye-bye.